Good afternoon, everybody. My name is Csaba Novak. I'm from Budapest, Hungary. My case is a multi-stage open-endo repair of a type A aortic dissection. So our case is a 56-year-old female with a history of multiple abdominal surgeries due to colon tumor several years before. She's in complete response since. In 2006, she felt a sudden chest pain. CTA was performed, which confirmed type A aortic dissection. So she underwent an urgent ascending repair. And during the follow-up, we continued to see an enlargement of the residual type A dissection. We did a genetic testing for connective tissue disease due to the early onset of aortic dissection, but it was negative, but the aorta continued to dilate. So in 2013, it reached 4 centimeters at the infrarenal segment and 3.5 centimeters at the left common iliac segment, which is also involved in the dissection. In 2019, the infrarenal segment reached 6 centimeters. The left common iliac segment reached 45 millimeters. At this point, we decided to treat and to intervene. Aortic team decision was made to perform a multi-stage repair with an open repair of the aortic arch using a frozen elephant trunk technique. Second operation with a TVAR for the descending aorta, and finishing with a fenestrated repair and an IBD on the left side. So in 2019, October, she underwent a frozen elephant trunk repair. This is the preoperative CT angiography showing us the compressed true lumen and multiple small fenestrations along the intimal membrane. We decided to choose a 32 by 15 centimeter long hybrid graft. The fat repair was done using individual branches. Deep hyperthermic circulatory arrest was done with an 81 minutes of arrest time, 3.5 hour perfusion time, almost 6 hours total operation time. A long ICU stay was seen with a late extubation, which the patient barely survived. In 2020, March, we did a follow-up imaging on the patient. You see the quite compressed frozen elephant trunk device in the descending aorta and the perfused false lumen at the descending. So we continued the case with the planned TVAR in June 2020. The tapered Medtronic Navion was used 20 centimeters long. After this operation, you see a positive remodeling can be seen on the true lumen of the descending aorta, but still the false lumen is perfused. So in October 2020, we decided to continue with the third stage, fenestrated repair and the distal iliac bifurcation device on the left side. But there were some questions. A narrow true lumen was seen, which showed that it will be difficult to manipulate the device within the true lumen. There was a right renal arising from the false lumen, which needed a long bridging segment for that branch. And there was a compression of the true lumen at the proximal common iliac artery, which we wanted to perform an IBD procedure on. So this is what you see here. The left common iliac artery true lumen is almost completely compressed. At the visceral segment, the true lumen is quite compressed, and the long bridging segment is needed for the right renal artery. We performed the cannulation of the true lumen from the left femoral artery. Once we confirmed that we are in a good position, we continued with the insertion of the fenestrated main body, cannulated all 4 branches, started with the SMA in this case, just to be sure that we will have that branch secured. We continued with the right renal artery, left renal artery, and finished with the celiac trunk. After we finished the fenestrated repair, we continued with the IBD on the left side. We inserted the device, cannulated the left internal iliac artery, stented, and finished the operation with the unibody and the interconnecting limb between the unibody and the left iliac bifurcation device. This is the discharge CT after the fenestrated repair, the third stage operation. As you see here, there's a filling of the false lumen around the right renal segment. which raised the suspicion of a type 3 endoleak around or in connection with the right renal bridging device. So we did a re-intervention on that in this February. But the aortic segment was long enough, so that was not a modular disconnection between the renal and the aortic segments or devices, but rather a fabric tear along the device, which was confirmed by wire manipulation. Once I wanted to insert the guide wire to do a relining, it went out through the struts without any resistance. So we did a relining to achieve a sealing of the aneurysm or the false lumen, and schedule the patient for the 6 months follow-up, which will be due this summer. So this was our patient between the stages of the operation. It was quite difficult to maintain compliance of the patient. So to summarize the conclusions, a type A aortic dissection repair is a never-ending story. All operations will be staged sooner or later if you have a long enough life expectancy. IBD and a dissection is surprisingly easy once you find the true lumen, but you should have to keep an eye on cover stents in areas without wall opposition and external support.